Okay, sir. So we are live, and with all your concerns, sir, I'm starting today's session.
Sure.
So, greetings and a warm welcome to everyone. This is Rupsha, the assigned moderator from Learnit. It is my sincere pleasure to extend a heartfelt welcome to all the delegates joining us across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us on today. Now, allow me a moment to introduce our platform, Turnit. It stands as one of the largest live digital CME platform in India, providing a space for doctors to create and share their medical content. Now, I would like to extend a special welcome to today's distinguished speaker, Dr. Utpal Sarmah, sir, that has completed MBBS, MS in ENT, otorhinolaryngology, and associated with Tezpur Medical College and Hospital in ENT and head and neck surgery. And the topic of his today's session is long-term complications of laryngopharyngeal reflux. So, long-term complications of laryngopharyngeal reflux are associated with chronic irritation and inflammation of the laryngeal and pharyngeal tissues due to backflow of gastric contents. Persistent exposure to acidic and non-acidic substances is linked to laryngeal mucosal damage, which can result in conditions such as chronic laryngitis, vocal cord nodules, and granulomas. So, without any further delay, sir, I would like to hand over this topic to you. Please proceed with your talk, sir. Over to you. Thank you.
Thank you, Rupsa. Thank you, Clarinet, for giving me this opportunity. Today, the topic of discussion is long-term complications of laryngopharyngeal reflux. But rather jumping into the complication, it's very essential for us to know the pathophysiology of this complication. So I will stress most of my time in explaining the pathophysiology of this disease, which lead to its various complications. So, as we all know, laryngopharyngeal reflux disease is a disease which typically results from the effect of the reflux on the glottis and the vocal cord. It is also known as a silent reflux or an extraesophageal reflux or a supraesophageal reflux. Now, as we all know, the gastric acid is sequestered in the stomach. Okay, but when it escapes into the distal esophagus, sometimes it can spill over into the pharynx and the larynx also, and this may lead to hoarseness and other symptoms due to which the patient presents to us. We need to know the difference between the laryngopharyngeal reflux and the gastroesophageal reflux, because most of the time there is a confusion that we most of the time confuse them as the same disease, but these are not same. There are certain differentiation that help us in like knowing which disease is what. Like the gastroesophageal reflux is mostly due to the dysfunction or the laxity of the lower esophageal sphincter, whereas the laryngopharyngeal reflux is mostly due to the dysfunction of the upper esophageal sphincter. In the gastroesophageal reflux, the damage is mostly due to directly due to the gastric acid, whereas in laryngopharyngeal reflux, the damage is due to the acid activated pepsin. It is very important to know this. Then in GER, the symptoms are also little bit different from the LPR. However, most of the symptoms they like tend to be similar. Like heartburn is more prominent in GER, however, it is not that prominent in LPR. In LPR, the patient mostly present with cough and hoarseness, and sometimes they are also treated as cases of URTI. And in GER, it's mostly nocturnal reflux, supine reflux. That is when the patient is lying down, the patient will experience some sort of reflux. But LPR, as we have already know, the another name is silent reflux. So the patient will not be aware of the reflux, and it is a mostly upright or a daytime reflux. Now coming to the pathophysiology, four barriers to the reflux of gastric acid from the stomach to the esophagus and upwards. The first barrier is the lower esophageal sphincter. The second one is the upper esophageal sphincter. The third one is due to the peristalsis of the esophagus. The fourth barrier is the epithelial resistant factors. Now, dysfunction in any one of these above may lead to LPR. Okay. The upper esophageal sphincter is the final gatekeeper against the reflux of the gastric contents. The distal pharynx and the upper esophageal sphincter should, like under physiological conditions, most of the time the upper esophageal sphincter it remains closed. Okay, only during conditions such as swallowing, only it gets open. But even sometimes if there is a laxity, then this barrier is breached and the acid flows upwards till the pharynx. Now there are some complex group of muscles that constitute this barrier to this acid, and it comprises of the cricopharynges, the thyropharynges, the proximal cervical esophageal musculature, and they form a C-shaped sling, and it all of this get attached to the cricoid cartilage. Sometimes the tonic pressure which is induced by these muscles like this can however be decreased with general anesthesia, sleep, or cigarette consumption. So these things needs to be avoided. Okay, however we cannot avoid sleep, but like cigarette consumption obviously can be avoided because it is one of the most common etiological factor which is known to cause LPR. Now, one more thing we need to know is that the pH of the pharynx is neutral. It is around 7, and the pH of the stomach acid, as we all know, is around 1.5 to 2. If there is a reflux into the of the gastric contents into the esophagus, up to 50 reflux episodes per day are considered to be normal. But if this reflux of the gastric acid reaches the pharynx or the larynx, then even 3 episodes per day can cause damage. Now, this damage is mostly due to a combination of the acid and pepsin. Now, if you see the pathos, there are various theories that have been like proposed to for the pathophysiology of LPR. We'll discuss some. Like one theory says that there is the direct exposure of the gastric acid which damages the laryngeal epithelium, and when the laryngeal epithelium gets damaged, the ciliary flow is impeded at 5 pH of 5, and it gets halted at around pH of 2. And due to this retrograde flow of gastric acid and pepsin, it induces a laryngeal mucosal damage and impaired mucociliary clearance. One of the things that I have already mentioned is pepsin. Pepsin is a very important component in the pathophysiology of LPR. We need to understand this. Not only the gastric acid, but pepsin is the considered to be a main culprit. Like there are many theories going on that says that pepsin is the key component that leads to the damage of the mucosal and laryngeal mucosa. Pharyngeal and laryngeal mucosa. Uh, Now, how pepsin acts is that it's disrupt the laryngeal barrier function predominantly via E-cadherin cleavage proteolysis and downstream the matrix metalloproteinase downregulation. There is another theory which has mentioned that the reflux of LPR it includes pepsin, gastric acid, bile acids, and trypsin, and all of this refluxate they tend to trigger an inflammatory cascade response, and when the reflux is transported into the airways, it is buffered into weak acidic and some non-acidic substances. Now the airway mucosa damaged have been hypothesized due to this, mostly due to the non-acidic substances rather than those acidic substances, leading to those frequent irritative throat symptoms. Now we can summarize the pathophysiology. There is a, obviously in this case there is a, since it's a reflux disease, so there is a reflux of the gastric contents into the larynx. So what it causes, that there is a direct mechanism they have proposed and there is an indirect mechanism. The direct mechanism is that it damages the cilia, causes impaired mucociliary clearance, and this impaired mucociliary clearance it leads to mucostasis. and due to this there is repeated throat clearing and cough. And then this continuous cycle, this continues, this there is a cycle of laryngeal inflammation and irritation. And there is that another theory of indirect mechanism where the acid in the distal esophagus, what it does is that the acid in the distal esophagus, it stimulates the vagus nerve. Okay, and this vagus nerve stimulation leads to bronchoconstriction, chronic throat clearing, and coughing, also known as the esophageal bronchial reflex. And this leads to the formation of some mucosal lesions. Now, if you come to see the etiology, the most common etiological factors are diets heavy in acidic or fatty foods, caffeine, alcohol, eating large meals before going to sleep, obesity, smoking, tobacco consumption, and drugs like benzodiazepine, calcium channel blockers, tricyclic antidepressant, and NSAID. All these are some of the etiological factors that contribute to this disease. Now, this disease gets aggravated by two things, mostly two things. There may be other also, but most common thing that aggravates the disease is the vocal abuse and chronic cough. And as I have already mentioned, this chronic cough is mostly due to this esophageal bronchial reflex. The acid in the distal esophagus, it stimulates the vagus persistently, and it leads to a like phenomenon of persistent cough. Now, clinical features. These patients with laryngopharyngeal reflux mostly presents to ENT specialists and gastroenterologists, general physicians, and pediatricians. Uh, the symptoms may vary. Okay. However, hoarseness is found to be prevalent in almost 100% of the cases with LPR. And another symptom which is very common is the globus sensation. Globus sensation is feeling of something stuck in the throat, like a lump in the throat. Okay, patient mostly come to us and describe it, something is stuck in our throat. I feel something in my throat. The complaint is like that. And then there is a history of throat clearing, persistent throat clearing, mucus or post-nasal drape, which leads to recurrent cough. Sometimes the patient might also have dysphagia. There is coughing on lying down or coughing after eating. Sometimes in severe cases, there might be breathing difficulties, choking episodes if there is severe laryngitis, chronic cough. Uh, some of the features, they overlap with features of uh, your LPR, like heartburn, indigestion, and regurgitation. However, the regurgitation is not that prominent in laryngopharyngeal reflux. The patient doesn't say that I have got a regurgitation. Rather, they come to us mostly with the complaint that there is something stuck in my throat, there is hoarseness of voice, there is pain in my throat. The symptoms are like that. Now, the important tool for us to diagnose it clinically is a video laryngoscopy or fiber optic laryngoscopy. On laryngoscopy, there is thickening and pachydermia of the posterior laryngeal commissure and postcricoid mucosa. Mostly the posterior part of the glottis is involved, not the entire, but the posterior part is involved. There might be some granulomas formation in the vocal process of the arytenoid. Granulomas in the vocal cords can also be seen. There might be edema of the folds and the true vocal cord. There might be some mucosal ulcer. There might be a pseudosulcus of the vocal cords. Uh, Sometimes, in rare cases, subglottic stenosis has also been reported. However, it is very uncommon to find such patient that the subglottic stenosis has happened like barely due to this laryngopharyngeal reflux. However, it is a very important, it can be a very important contributing factor for subglottic stenosis. So in this diagram, in this clinical picture, you can see the mostly the posterior glottis involved. It is edematous, it is inflamed. There is one nodule also in the vocal fold. Now, how do we evaluate such patients? Now, it is very important for us to prove that there is this retrograde flow of the stomach acid into the upper ear aerodigestive tract. And this is considered to be a gold standard. And how do we achieve it? We achieve this by doing a 24 hours pH manometry, pH monitoring. Sorry. Uh, Now, what is a pathological reflux? We need to know what is a pathological reflux. Pathological reflux is considered to be present when there is a pH of less than 4 for at least 1% of the study time. Alternatively, video fluoroscopy can also be performed, but rarely done, and it has not been shown to increase the sensitivity of the diagnosis. So, a 24 hours pH monitoring is considered to be the gold standard for diagnosing LPR, apart from the clinical signs that we elicit by visualizing the larynx. There are some questionnaires or tools to assess the severity and impact of LPR. These are the reflux symptom index. We can also use the reflux finding score. There is this voice handicap index and reflux symptom score. Another tool that can be used is the uh, pepsin measurement in saliva and pepsinogen level of middle ear fluid. One thing I'm going to deal later is that this LPR can is found to be a contributing factor for otitis media with effusion, especially in children. So in those cases, we can, if any such patient has got found to have a picture of otitis media with effusion, that fluid can be aspirated and sent for pepsinogen levels. Now, how do we manage this condition? To manage this condition, lifestyle modification is considered to be the mainstay of treatment rather than depending on drugs. It is better that the certain amount of lifestyle modification which can help us in controlling this disease. These include weight loss, decreasing the meal size, refraining from lying down immediately after a meal, low fat diet, avoiding carbonated beverages, caffeine avoidance, alcohol avoidance, and minimizing tobacco intake. So, lifestyle modification is a very important component in the management of laryngopharyngeal reflux. And then there are medication, the H2 receptor antagonist, the proton pump inhibitors, antacids, antipepsins, the alginates. So, along with medication, the lifestyle modification is very important. Empirical treatment for laryngopharyngeal reflux is last for around 2 to 3 months, and we should also consider this. It is a very like irritative disease, lasts for a very long time, and it requires a more aggressive and prolonged therapy than gastroesophageal reflux disease. There are some newer drug like therapy available now, like some are still in your drug trials. Some of them are mozamprenavir, emprenavir, Vocuzina. Now, all these drugs they tend to prevent pepsin-mediated epithelial damage rather than working on decreasing the gastric acid secretions. In severe cases, where sometimes surgery has to be considered, it is the Nissen fundoplication, which is most commonly done. Now, coming to the complication, I hope that you might be able to comprehend the pathophysiology of how that gastric acid lead to damage of the laryngeal and pharyngeal mucosa. So complications include recurrent vocal fold scarring, and this leads to hoarseness of voice, chronic cough, There is recurrent laryngeal inflammation, oral cavity ulcers, recurrent bronchopulmonary infections like pneumonia. Squamous cell carcinoma or laryngeal carcinoma has also been seen in patients who are suffering from laryngopharyngeal reflux disease for a long time. And subglottic stenosis. Cases of subglottic stenosis have also been reported, however, very rare. For children, mostly like children, they are not going to complain anything regarding the reflux. And it is a silent reflux. So, mostly in children, they might sometimes present with otitis media with effusion or recurrent sinusitis. So, we have to be watchful for that. And in patients with laryngomalacia, those child newborn who are born with laryngomalacia, this if the laryngopharyngeal reflux is present concomitantly, then it can aggravate the symptoms of laryngomalacia and can also impact the surgical outcome. So in such cases, laryngopharyngeal reflux management with proton pump inhibitors is also essential. Now, for consultation, uh, a multimodality treatment uh, is essential, as I have already mentioned. If a patient continues to have symptoms of hoarseness, dyspnea, sore throat, despite lifestyle changes, uh, otolaryngologist referral, along with for fiber optic laryngoscopy, along with a gastroenterologist referral for esophagoscopy is essential for a complete evaluation of the patient. So, in a conclusion, it is a very frustrating disease. It incurs a high cost to the patient and society, given, given its typical recurrence and requirement for prolonged treatment. With time, however, and with appropriate intervention, the laryngopharyngeal symptoms can resolve. Patient education is very crucial aspect of the management. Lifestyle modification, it constitutes the first line of therapy, and a collaborative interprofessional team can help improve outcomes in patient with LPR. So I hope this was a helpful session for you all. So with this, I conclude. Any questions are welcome. Uh, Thank you.
So, thank you so much, sir, for this wonderful deliberation. And yes, sir, we have received a couple of questions from our participating doctors. So, sir, may I stop your screen share from my end so that I can share my
Yeah,
screen
sure.
for the Q&A?
Sure.
Okay, sir. Thank you. Sir, is my screen visible to you?
Yeah, sure. Yeah, it's visible. So this question is there: in patient with refractory LPR despite optical medical management, what advanced diagnosis or therapeutic options can be considered? This way. So if the medical management, so I've already discussed this thing. So if the medical management fails, then we might have to sometimes consider surgery also. The newer drugs are also available, but they have not been tested for many patients. So we can't see the efficacy of those drugs. But however, if the medical management fails, sometime we have to go for surgical option like Nissen fundoplication. Thank you. Are there any other questions? Yeah.
Yes, sir. This is the second question.
How long? How can the long-term effects of LPR on voice users such as singers and teachers be mitigated? Uh, for that, we need to educate them. See, they are going to use their voice because it is their bread and butter. so we cannot stop them from using their voice. So in such cases, like we might have to consider giving them therapies at like for a long term interval and stop in between, get a regular evaluation of their vocal cords by doing a video laryngoscopy. Okay, so we can like detect those changes early by visualizing that, and then we can educate them properly. Sometimes even speech therapy, voice therapy might be required from a speech language pathologist. Okay, I hope this helps.
Sure, sir. So we're moving on to our next question.
Relationship between laryngopharyngea and chronic conditions such as diabetes or obesity. Now, obesity is related to LPR, but for diabetes, I have not found any literature which has mentioned the relationship with diabetes with LPR. If there are any, I'll try to find it out more. But I have not found any article which links diabetes and LPR. But obesity is surely linked with it. The more obese a person, the more symptoms he is going to encounter. Okay, and the prognosis is bad for obesity. I don't know about diabetes, but for obesity, like weight reduction is a very important thing we tell our patients to. If the patient is suffering from LPR and if the patient is obese, so we tell them the first thing is that weight reduction. Okay, how do long-term complication of LPR and period differ from those in adults? What are the unique challenges in management? Pediatric patient, they normally like LPR is mostly like you can't label a pediatric patient as a LPR, because see, the classical symptoms are not present in a pediatric patient. He will be coming with some other symptom, and if we go retrogradely, then we can like yes have an idea that yes, this, if we can't find any cause, we can say this, yes, if this patient might have LPR. Okay, we have to go with trace the history, go backwards, how is his diet, inquire about his diet, and try to do a laryngeal endoscopy or an esophagoscopy to see if he is having those clinical changes. Unique challenges in management is that LPR requires a long-term therapy, so adherence with it, okay, the compliance. So these are the challenges.
So thank you so much, sir. These are the questions for today's session. Thank you for answering the queries of our participating doctors, sir. And I would also like to thank all our participating doctors for their continuous participation at our platform and request all of them to stay more updated on us. You can follow us on our social media pages like Facebook, Twitter, LinkedIn, and on Instagram. So, sir, with this, I would like to conclude today's session over here and looking forward to host you again. Thank you so much, sir.
Thank you. Thank you,
Thank
Rupsa.
you, sir.
Thank you,
Have a
Clarina.
good day.